This is One in Five, a podcast from Providence about disability and the intersections with healthcare. I'm Sarah Quinto.
And I'm Angela Marith. Cera, in our last episode, we talked about how at Providence we really welcome people with disability. And we had some help with listening to Eric Wexler and Jeff Cato have a conversation. Eric Wexler is our former Chief Operating Officer and incoming Chief Executive Officer at Providence. And they talked about Jeff's journey at Providence as an employee who is blind. I'm really excited that we're going to hear their full story in episode 5, You Need Us.
I am excited to hear that too, Angela. I can't wait. I'm also excited for today's podcast. We're going to be talking about some of the common experiences of people with disabilities when accessing care. We are going to explore what they want their healthcare providers to know. The first person we're going to hear from today is Jennifer Kucera, who is a lifelong advocate for people like herself with a disability. She lives in Cleveland, where she's a member of Ohio's Developmental Disabilities Council, and she also advises United Healthcare on people with complex care needs. Let's take a listen.
My name is Jennifer Kucera. I was born with a developmental disability, a form of muscular dystrophy called spinal muscular atrophy. And I have been an advocate ever since I've been old enough to speak. I've always advocated for myself, and I've realized that I, do have the ability to turn my thoughts into words. And I just have seen so much throughout my life, injustices to people with disabilities in my own experience, and then getting to know others with disabilities to see the stories and to hear the stories of what has occurred to them throughout their life. Most of the work that I do is in the healthcare space because there's so much work that still needs to be done to bring healthcare to people with disabilities and to serve them as we need it to be done.
You say to people in healthcare, people with disabilities have a difficult time, and they'll say, what do you mean? and you're like, well, where do you want me to start? Would you mind just sharing a little bit about some of your experiences?
Sure. You may have to cut me off because this could take a while. I know that when I talk with other people with disabilities, they often say, and we often agree, that we will probably die from something that would have been easily treated had we been able to get treatment. For example, I am 55 and I have had 2 mammograms in my entire life, because the machines are impossible to navigate for a person that uses a wheelchair. And my power chair that I have is really the Mercedes-Benz of power chairs because it lifts up and it can tilt back. And I still can't get to the machines where they can position me enough to be able to do a successful mammogram. So diagnostic equipment is one big area where we see that people with disabilities cannot utilize the machines. They need to be redesigned with people with disabilities in mind. Along with exam tables, a lot of times I've gone to hospitals and smaller clinics that their exam tables, there's no way. I cannot transfer by myself. I have to utilize what's called a Hoyer lift, which is kind of looks like an engine lift where they lift you up and then they move you. Places won't have Hoyer lifts, and if they do, the staff will not know how to utilize them. I'll have to do my own training as they're moving me in the air to move me from point A to point B. Sometimes they're not plugged in, even if they have them, so they're not charged up. But, even that being said, once I get to the exam table, it could be too small, too high, to, not be able to accommodate my body. Even if I call ahead to a place that I'm going to go to, to try to ask them either to send me pictures of the exam table, they're like, well, it's an exam table. I'm like, and they don't understand what you mean when you say, well, I need to know the specifics, because I don't even know if my body, first of all, will be able to transfer to it, and if I will be in extraordinary pain as I'm laying on that table.
okay, you've got these infrastructure problems, but then you also have these sort of attitude problems. I mean, for lack of a better phrase, what happens? What are people's reactions to you when you ask for those supports?
Yeah, they don't understand. They'll say it's just an exam table. I don't have time for this. I'm too busy for this. If you're worried, go to another place, another facility. I even stayed in a nursing home for a couple years, and there was an appointment to a specialist that the nursing facility set up. So I had to be transported there via stretcher. And when I got there, we had to wait out in the hallway, and the receptionist came out and said, "Oh no, you can't be here." And the drivers are that were going to drop me off. We're like, "Well, what's going on?" And they're like, "Well, we don't have any room for that." And they didn't even use me. They said that the receptionist said, "Well, there's no space for that," and we literally had to leave. You go to see a doctor and you're going for a reason. You are going because you're sick, and you don't really want to deal with these issues because you just want the doctors to be able to help you, and they're supposed to be the ones that are in the know. I truly also don't think doctors and nurses and other staff have enough awareness and education surrounding disability. I know I've heard, I don't know for sure, but like in a lot of doctor training programs, they only spend a week on disability. More will change, I'm sure, in the future, but it is through conversations like we're having right now that are very important to have between people with disabilities and parents of children with disabilities. Just continue this conversation. Continue educating the people that are around you. I won't stop until I can't speak anymore.
Angela, when I listened to it this time, the thing that I heard was that she wasn't even referred to as a person. Her provider referred to her as that.
Yeah, I know. That part really just, I don't know, it's like hit me in the gut. When the provider sees the wheelchair, she disassociates from the fact that this person is actually a person. She just sees the wheelchair. Also, when she stated that, when Jennifer stated that she and her friends are sure they're going to die of something preventable, it actually reminds me of one more part I want to play of this conversation that you had with Jennifer. This is where she talks about her sexual health.
Throughout my life, when you go to the doctor's office and they always ask you the question, if you're a female, if you might be pregnant or possibly being pregnant, and that's one of the questions. I was never, ever asked that from whatever age that is supposed to start till now. Nobody has ever asked me that question. And sometimes, just because I like to be stubborn, I'll say, "Why aren't you asking me that question?" And they're like, "Oh, well, you can't be pregnant." I'm like, "And why not? I'm a female. All of my body parts that, are supposed to work. Who's told you that, there's nothing in my chart that says that I could not have had children when I was of childbearing age." And my sexuality was also never discussed. Everything that I learned about it, I either learned from my parents or reading books or the internet and friends. But the medical staff, that's one question that still, human sexuality is not touched with people with disabilities.
The thing that really stands out to me when she talks about not being asked about her sexual history or her sexual health is that's not just, dismissing her, which it is, but it's also dangerous.
Yeah.
Right? Like she needs that health care. And the fact that she's not receiving it or no one thinks to provide that to her, that's a serious health disparity that she's experiencing.
Absolutely. I mean, the assumptions that are being made because she's in the wheelchair are just shocking.
I mean, and good for her that she, she stood up for herself and she said something about it to her providers.
Yeah, absolutely. Jennifer's really cool. I'm glad we got to talk to her and get to know her, but
Me too.
and we can do better. Jennifer gave us a very honest description of her experiences with a disability, and her disability is very visible to those around her. However, disabilities are not always easy to detect. Cera, I think this would be a really good time to listen to a conversation that you and I had with Heather Harris.
Yeah, so Heather Harris is a friend of mine. We met in disability studies graduate school at City University of New York. Today, Heather works for the Office of Accessible Education at Stanford University. I want for us to listen to this conversation with Heather because it touches on an important point around intersectionality. Heather is very careful to define intersectionality as experiencing multiple forms of discrimination at the same time. And for Heather, this is race and disability discrimination. Let's take a listen. I'm wondering if you could speak a little bit about your sort of extended identities and where you've seen yourself fit in the disability community and where you felt you have not found a complete home in the disability community.
Absolutely. Yeah, there's a lot of different areas that different identities and the interlapping intersectionalities within those identities may create conflict. And I use the word intersectionality intentionally. I think today a lot of people use the word intersectionality as a positive. These are all the pieces that make me who I am. I myself, I am a Black biracial person. I am a person who's gender nonconforming. I am queer. I have disability that I today hold as one of my identities, even though that's not something that I used to hold. And all of those pieces of me are valid. I don't rank them. I'm not Black first, queer first, disabled first, any of that. It's the and not the or. I am all of those things. And I think it's important to recognize and be allowed to hold all of those pieces in a space that you're in.
Yeah, I'm so glad you brought that up because I think that oftentimes when we talk about disability, we have a very specific vision of who a disabled person is. And the reality is that, especially in the United States, we're so many things.
Heather, I'm hearing themes in terms of what you experience by this intersectionality of being Black, queer, a person who has a disability. How does that play out in getting medical care?
I think that nobody comes into the world trying to be discriminatory towards anyone, but there are unconscious biases that do make their way into medicine. Even though medicine and healthcare does its very hardest to be an unbiased field. There's old mythos, of course, about Black individuals and disability. Black people's skin is thicker or don't feel pain as much. They don't need much numbing. For myself, I noticed the intersection causing that discrimination in healthcare when I was 15. And what I now know to be multiple sclerosis was showing up for the first time. I was going to the ER and nobody could figure out what was wrong with me, but I was in such a severe amount of pain. And I would go to the ER and they would run their scans and their scans would say, oh, we don't see anything wrong. And at first they would send you home with a pain prescription. I don't know what's wrong, but here you go. And as I returned, I noticed that the attitude that the hospital staff had was changing. There is this unconscious bias that people may have in medicine that someone who comes from the Black biracial community, someone who comes from a low-income community. At the time, I was going to the only hospital that welfare insurance would cover, that certain communities may be drug seeking. And I very quickly reached a point where doctors were not willing to prescribe me pain medication anymore. And obviously, emergency care is not meant to diagnose a person. And so I eventually got connected to a specialist who spent months running me through my paces of all of these various, very painful tests. Whether that you want talking about a lumbar puncture or electrical stimulation, whatever it may be, trying to figure out what is matching up with the symptoms that this patient, me, is reporting. And one day, the doctor asked me to come into the next appointment and asked my parents to come with me because they'd figured out what was wrong with me. And I I cannot even tell you how excited I was. It's very scary to have the rug pulled out under you, go from track team to wheelchair overnight. Going through all of that and no one can tell you why is terrifying. So we came in and I'm waiting for this answer with a diagnosis. I can start treating it. And their official answer after months of testing was that I was faking it, that I just wanted attention.
Oh, Heather. I'm so sorry.
And looking back as the adult I am today, I get it to some extent. I was brown. I was young. The ER docs suspect that I'm a drug seeker because I'm always in their revolving doors looking for pain reliefs. But I thought the discrimination buck was supposed to stop with them. I was faking it. I dealt with a spinal tap, these needles, the electrical shocks through my extremities, all these tests for attention. And I feel like a lot of that came from not knowing what was there. You can't see the answers on your scans, and so you let your unconscious biases win that day and decide that the patient is just faking it. I think about a different doctor about 5 years ago. I went to the audiologist to investigate what felt like a recent worsening of my hearing. And at the end of that audiology appointment, the doctor was left uncertain. According to their equipment, my hearing levels had changed just a tiny bit, but not enough to amount for the amount of difficulty that I was reporting. And so the audiologist sat me down and said, hey, you do have X levels of hearing loss, but your performance on the speech comprehension portion of the test is way worse than it should be given those levels of loss. And that doctor had a choice to make there. They could have decided that since their testing showed my hearing to definitively be at a certain level that I was faking. But this doctor on this day decided to believe their patient. The patient is reporting something that I am not seeing on my scans. Maybe there's something going on that I can't see. They suggested that I seek additional testing with a different audiologist whose testing works differently than the standard audiogram.
Oh, that's a beautiful example.
Yeah, definitely.
That's medical care working right. Yeah.
It starts with just believing the patient.
Right.
And thanks to that additional scan, I learned that, I not only was hard of hearing, I had auditory processing disorder, which, with hearing loss, your ears are functioning differently, so you're not able to receive sound. With auditory processing disorder, you're receiving the sound, but your brain doesn't quite know what to do with it. It's sometimes been compared to like an auditory version of dyslexia. And I had both. My ears didn't know what to do with sound, and also I didn't hear it perfectly. And I was able to get that answer because the audiologist made the choice to believe their patient, to believe that, what's on the scan doesn't have to be everything, and not to fall victim, whether consciously or not, to subconscious biases about what a patient may bring in with them.
Why can't our story just be our own story? Why does it have to be, that someone else inserts a story about our experience? And Heather, that really came loud and clear when you were sharing about your experiences, is that there's always this insertion of an additional story where there doesn't need to be one.
Absolutely. I love that so much. Just let disabled people own their own stories. And it really should be a partnership here. Doctors do have their own medical expertise, and that is so invaluable as a piece of conversation. And so is the patient's self-report. You need both of those pieces together to get to the answer.
I often think about this care avoidance conversation, and it's like with 1 in 5 people in the US having a disability, you have to ask yourself if there's a connection, right, between, the proportion of people that avoid care and the proportion of people that have a disability, and just those experiences really informing that desire to not have another poor experience, and not have a repeat of the experience that came before.
Heather, I'm so grateful that you've taken the time to have this conversation with us today. Thank you.
Angela, Heather paints such a vivid picture of both the power that comes from the disability community, but also the isolation that comes from these healthcare spaces when you haven't been listened to.
Yeah. Heather and Jennifer have illustrated also the physical harm that biases about disability can cause. We absolutely need to do better as a healthcare community. And I'm ready. Are you ready?
Oh, I'm ready.
All right, let's do it.
Many thanks to our guests, Jennifer Kucera and Heather Harris. Thanks too to our colleagues Deepak Sadagopan, Scott Acord, Sean Collins, and the Disability Caregiver Resource Group at Providence. I'm Cera Quinto.
And I'm Angela Marith. On the next episode, Resilience and Value in the Face of a World that Undervalues People with Disability. One family's remarkable story. Get in touch with us if you're interested in sharing your experience of disability and healthcare. Our web address is providence.org/1in5. That's all one word spelled out, 1 in 5. Thanks for listening today. This is 1 in 5.